RX.
I am Lakshman Patil. On behalf of Emcure Pharmaceuticals, I welcome all the delegates to this No Thrombosis series. Doctors, I am very happy and glad to announce that Emcure has taken this initiative, that is No Thrombosis, and this has won 9th edition of SIMS Healthcare Excellence
I am
Award
Lakshman
in the year
Patil.
2020.
On behalf of Emcure
For
Pharmaceuticals,
its most engaging,
I welcome
scientific
all the
platform.
delegates.
So
to
No
this
Thrombosis is a platform which provides practitioners, doctors,
platform to share
I'm
their
very happy
insights
and glad
on some
to
of the
announce
real-life clinical
that
studies
Emcure has
of,
taken this initiative,
thrombosis
that is
management,
No Thrombosis, and
wherein
this
doctors
has
do
won
attend this
9th
and
edition of
interact
SIMS
their,
Healthcare Excellence
I am
Award in the
Lakshman
year
Patil.
2020.
On behalf of
gives a lot of
Emcure
insights
for
for
its
its most engaging,
I welcome all the
So for
delegates
this today's
to
No
this,
Thrombosis
No
is a
Thrombosis
platform which
where,
provides
I am pleased
practitioners,
to
doctors,
platform to share
I'm
their
very happy
insights
and glad
some
to
of the
announce
real life
doesn't require
clinical
any
studies
introduction. Emcure has taken
but
this
for the sake
initiative,
of
that is No
tradition,
Thrombosis.
it's my honor
And
wherein
to
doctors
introduce
do attend this
ninth
and
edition of
interact
SIMS
their,
Healthcare Excellence
I am
Award in
Lakshman
the year
Patil.
Sir has
2020.
completed
On behalf
gives
of
a lot of
Emcure
insights
for
for
its
its
most
most engaging,
I welcome all the
So for
delegates
this today's
to this,
No
Thrombosis
Thrombosis
is a
platform
platform
which
where,
provides
Dr.
Chandra
Chandra
sir
sir
is
is chairman,
introduce
division
share
of
very
interventional
happy
cardiology
and
method
glad
some
to
of the
announce
real life
doesn't require
clinical
any
studies
introduction. Emcure has
of,
taken
but
this
for the
initiative,
sake of
that is
recognized
No
as one of the
Thrombosis,
leaders
honor
in
and
wherein
this
doctors
has
do
won
attend this
ninth
and
edition of
interact
SIMS
their,
Healthcare Excellence
I am
Award in the
Lakshman
year
Patil.
Sir has
On
completed
behalf
gives
of
a lot of
Emcure
insights for
Pharmaceuticals,
its most engaging,
I welcome all the
For
delegates
this
today's
No
No Thrombosis is a
platform
platform of
which
coronary
provides
in India.
Dr.
I
Chandra
am
sir
pleased
is
to
platform
to
which
share
share
their
very
insights
happy
and
and glad
some
to
of the
announce
real life
doesn't require
clinical
any
studies
introduction.
international
Emcure
of
has taken
but
this
for the
initiative,
sake of
that is No
recognized as one of
Thrombosis,
the
it's my
leaders
honor
and
and
wherein
to
doctors
introduce
do attend
AMI
this and
9th edition of
interact
SIMS
their,
Healthcare Excellence
I am
Award in the
Lakshman
year
Patil.
Sir has
On
completed
behalf
gives
of
a lot of
Emcure
insights
for
for
its
its
most
most
engaging, I
engaging,
welcome all the
For
delegates
this today's
to
No
this,
Thrombosis
No
is a
Thrombosis
platform which
where,
provides
reviews and
Dr.
Chandra
Chandra
sir
sir
is
is
national and
platform which
Chandra
share
sir
very
interventional
happy and
cardiology. So I
glad
welcome
to
some of the
announce
real life
doesn't require
clinical
any
studies
introduction.
international
Emcure
of
has taken
but
this
for the sake
initiative,
of
that is No
recognized as one of the
Thrombosis,
leaders
and
wherein
this
doctors
has
do
won
attend
AMI
this
9th
and
edition of
interact
SIMS
their,
Healthcare Excellence
I am
Award in the
Lakshman
year
Patil.
Sir has
On
completed
behalf
gives
of
a lot of
Emcure
insights
for
for
its
its
most
most
engaging,
engaging,
I welcome all the
For
delegates
this
today's
No
No
Thrombosis
Thrombosis
is
is
a
a
platform
platform
which
which
provides
reviews and
Dr.
Chandra
Chandra
sir
sir
is
is
national and
share
Chandra
very
sir
happy
cardiology. So I
and
welcome
glad
some
to
of the
announce
real life
doesn't require
clinical
any
studies.
introduction.
Dr. Vinayak
Emcure has taken
was
this
the head of the
initiative, that is
recognized
No
as
Thrombosis,
is my honor
and this
doctors
has
do
won
attend
AMI
this
9th
and
edition of
interact
SIMS
their,
Healthcare Excellence
I am
Award in the
Lakshman
year
Patil.
Sir has
On
completed
behalf
gives
of
a lot of
Emcure
insights for its
for
most
his
engaging,
I welcome all the
For
delegates
this
today's
today's
No
No
Thrombosis
Thrombosis
is
is
a
a
platform
platform
of
which
coronary
provides
reviews and
Dr.
Chandra
Chandra
sir
sir
is
is
national and
share
Chandra
very
sir is
happy
cardiology. So I
and glad
welcome
to
some of the
announce
real
doesn't
life
require
on research and having conducted numerous clinical trials. I welcome you, sir, for this meeting. Then again, we are also joined by Dr. Tapish Sahu, sir, as a moderator for tonight. Dr. Tapish Sahu, sir, is a vascular surgeon with more than 19 years of experience. Sir has completed MD, DNB, FSCC, and FESC. Sir, he's also completed fellow vascular and endovascular surgery at Salk LKH Salzburg, Austria. Sir is presently working as a head of Department of Vascular and Endovascular Sciences, Manipal Group of Hospitals, New Delhi. Sir has published many articles and also involved in many clinical trials. I welcome you, sir, for this meeting. Then today's we have two speakers who will be presenting their interesting cases. First case will be presented by Dr. Digvijay Sharma, sir, who is a head and senior consultant, vascular interventional and surgery, Fortis Escort Heart Institute, Oakland, New Delhi. The second case will be presented by Dr. N.R. Shastri, sir, who is a consultant at preventive and non-invasive cardiology at Mulchan Hospital in New Delhi. So I welcome all the distinguished faculty, and now I request to Dr. Chandra, sir, to take the meeting forward. Over to Dr. Chandra, sir.
So I request Vinayak Agarwal, sir, please take it ahead. One Chandra sir is also joining, sir.
Yeah, Dr. Agrawal, sir.
Yeah.
So I welcome you all, and Dr. Chandra has joined us. Sir has joined us, so I guess he can
Yeah.
take over.
Sir,
Yeah.
good evening, sir. Sir, you are on mute, sir.
Acha, sorry. Now is it clear?
Yes,
Yes,
sir.
sir.
Yes,
Yes,
sir. It is
sir.
clear, sir.
So I
Oh,
welcome you, sir, for this meeting.
okay, fine. So I am just, is the image not coming properly or what?
We can see you
Yeah,
properly,
it
sir.
is coming, sir. It is coming, sir. Yeah.
Acha, ठीक है. Fine. So
So we just
everybody
completed
is
introductions, right, sir?
Sir, we just had an introduction, so we would like you to set the agenda for the meeting, sir.
Okay. So basically, today we are going to, again, as we have discussed in the past, about the, various aspects of particularly, challenging cases of cardiology, and Tapesh, Vinayak, Dr. Digvijay Sharma is going to present it, and Dr. Shastri, my colleague, is also going to present. So I think, this is a very interesting, very practical, discussions which we have been doing for the last, almost more than a year, I think. Vinayak, I think it's more than a year, maybe 2 years.
Yes,
So,
sir. I think
long
it's very
series.
interesting,
Yeah,
and we all learn a lot from our colleagues here,
each other,
especially under your guidance, sir. It's
No.
always,
So it will be interesting today also. And so we are going to start with the first presentation by Dr. Digvijay Sharma, who is the head and senior consultant, vascular surgeon, and interventionist from Fortis Escorts. So Dr. Digvijay Sharma has joined.
Yeah, yes, sir. Yeah, he's there, sir.
Okay, wonderful. So we can start with his session.
So, evening everybody. I'll present 3 short cases to give a wide spectrum of where we land up with a big thrombus burden. So, first case is a 53-year-old male. His primary presentation in Patiala was flash pulmonary edema with acute renal failure. So, predominantly admitted under nephrology in Patiala. After they sorted him out and worked him up, they found an acute thrombus burden in the aorta. It was a mid-aortic syndrome, and then he was referred to us. So we took him up for the procedure, and this is what it looked like when I go from below, and this is from the brachial axis. This would be my first pass with penumbra indigo after lacing the thrombus burden with HLX. And we started opening up the aorta. You notice there's a huge thrombus burden still. We had about 4 passes of penumbra indigo cat 8 with that separator, and finally managed to open him up. A very quick video about what it looked like before and after. Now we get a good clean aorta supply to the mesenteric vessels, and surprisingly, one of the kidneys we could save even after about 8 days of the primary insult. Now, the second case is a 42-year-old male. He presents to us.
So we can discuss a little bit here, Dr. Digvijay. I
Yeah,
think, this was a very interesting case. So first of all, this case came to you after how many days of acute presentation?
About 5th or 6th day, they had referred it to me.
Oh, so till then he was actually having collateral perfusion to the lower part of the body, right?
Yes.
Yeah. And what was the cause of this big thrombus which came in?
At that age, I would say it was Takayasu's arthritis variant in the mid-aortic syndrome. And, we had a big long segment of stenosis after we removed the thrombus burden. So it was I would say it is Takayasu, sir.
Oh, okay. Yeah. Okay.
There is no other diagnosis to really put it there.
In Takayasus, generally the balloons, actually, we had to go to high pressures and all that. In this case, what was the balloon you used? What pressures did you go? What size was the balloon?
It was
And
the
some
non-compliant
details.
plus. I started from 6 and went up to 12.
Okay.
They took me a long time. It was about 3 to 4 hours case.
Yeah.
Getting the access, getting through, externalizing both the wires, making sure I'm right in the intraliminal area, because I didn't have, it's from the mid aorta to about half of the ilex. So it took me time to clear it up. Yeah. Unfit for surgery because he had a previous MI or something, so I couldn't take him up open at all.
All right. So what is the post care now you have given to that patient?
Sir, after this, I referred him back after stabilization to the primary centers, and they told me that his left-sided kidney started functioning. So he is not on regular dialysis now. So he is there.
And he didn't have any end organ damages in intestine anywhere?
No,
Yeah?
sir, not in the intestine, but we lost his right kidney.
Right kidney was lost. Okay.
And
All
he's getting those anti-inflammatory and other things to manage his Takayasus. I've seen him once after the procedure. Uske baad, I have not been called for that patient yet, sir.
So tell me, like if this patient would have been in your care, for
Mhm.
example, so what will be the medical therapy you will give to this patient on a long-term basis?
Sir, we will first try to induce a remission. That would be steroids and anti-inflammatory agents most of the time. And because he's already 50, we don't expect another attack to happen. Takayasus generally wane off by 50 to 53. So after this, we expect him to settle out, sir.
Right.
By
And
the
what about antiplatelets and anticoagulants?
But they continue, sir. He will be on Xarelto plus Ecosprin now. For the first 6 months, he was on proper anticoagulation. Then we shifted him on PAD protocol, that Compass Voyager trial thing.
So
Tapish, are you here?
Yes, sir, I'm here, sir.
So any comments from you about this case? Would you do anything differently? You agree
Sir,
with Professor?
actually, this is the diagnosis of exclusion, as Professor Digvijay said, that actually in this case he was sick and there was nothing more that could be done. So I think that, well, in this age and case with this kind of presentation, I think I would agree with Dr. Digvijay here.
So you would do absolutely similarly, like you use the Penembra, you would use the same device or Angiojet or something like that.
Sir, yes. So there are debates on that. The thrombosuction, thromboaspiration, thrombolysis, some catheter-directed thrombolysis, as well as low-cost thrombolysis. The target remains the same, that you have to get rid of the thrombus time, and like he said, that after it was unmasked, then the lesion was more apparent there.
Right. But generally, in a patient who has Takayasus, if it was not an acute presentation like this, and if patient comes with claudication and stuff like that, then generally
medical management is the way to go,
yes,
sir.
Yeah, medical management, and then if the patient is still symptomatic and if there is no activity, then only we go ahead and do the intervention. As far as we used to do that.
It's not a long living intervention, because the disease process is there and it would go down.
Yes.
If it's not acute, then we would really push it as far as possible, and everything, even surgery, will be not. The anastomosis would go down after some time. It will go into fibrosis, because it's a continuing disease process. So it's more of a medical management in arthritis than surgical. So if it's really necessary, like acute, then it's really warranted.
I will add 2 things to this. At this age, intervention would be my last choice. I did it because there was no way out.
Yes,
that's right. I totally agree.
Absolutely, I would not go in this case. And even if I would, at this age, if he was fit, I would, if he had severe debilitating claudication, I would find the healthy aorta and do a proper bypass for him, supraceliac to wherever. Intervention this I did because we were in a fix there. We had to do
No, I
something. And
think it was quite life-saving. So you can go to the next case, Dr. Digvijay.
Sure. Now, this is a 42-year-old male. He presented to me with acute right leg DVT. We call it acute if it is less than 2 weeks old for DVT. Then, now why I present these cases, there are, when you want to do a DVT pharmacomechanical management, you should be prepared for a approximately 3 days thrombolytic period to really get a proper clearance, even after pharmacomechanical removal of the clot. You will not remove 100%, some will remain. So we don't want to puncture a big 8 or 9 French catheter into a big popliteal vein and keep them for 3 days or so in the ICU. So our preferred access point would be the short saphenous vein because it is relatively superficial, easily straight available right under there, and we can clean up those things. But if you don't have a short saphenous vein, then my center, we like to start with the posterior tibial vein for a lacing of the thrombus burden so that suction is more clean. So we go for a posterior tibial vein access and then we lace the thrombus. Then we shift him to the prone position, take an access to the popliteal vein and then do a thrombolysis, remove that popliteal catheter and then proceed with the prolonged thrombolysis via the posterior tibial vein itself. So this is how we would go about it. This is the posterior tibial vein with our catheter in it. We lace it up. You can see the thrombus burden, and after 30 minutes, the shot is a bit cleaner. This is the harvest, and once you put in the single pass of penumbra, you see there's a class 3. You can even see the valves when it all opens up. Now, this is the deep femoral vein. Now, when you go to the ilex, you see there's a total occlusion there. Collaterals are there, signifying chronicity. Then we blow it up and put in a stent to give a unrestricted flow to the IVC. Similarly, this is another case, no short saphenous vein, 30-year-old female, postpartum DVT, acute extensive, again micro puncture, same thing was done. This time I used angiojet. I had needed 2 passes to obtain a class 3 lysis, which was followed by balloon dilatation of the stenosis. In the pre-op counseling, the patient had flatly refused a stent, no matter what amount of stenosis I get in the iliac vein. And 10 French sheath was removed postpartum, 3 days, 72 hours. We again gave from the posterior tibial vein access my thrombolysis protocol, and we obtained quite a good clearance. This is how we would go in. This is where we are. This is the initial shot, and this is after we get an access. Then this is your angiojet going in. After completion, we get, you can see that the iliac vein is stenosed, but because, and it is significantly stenosed, but because of flat refusal for stenting, I just did as much angioplasty as I could do and let it be. What you want to tell is, if any thrombus burden is beyond the, is proximal to the inguinal ligament and it is acute, we prefer to take it out. Nowadays, they would, most of them would prefer a needle-based therapy. So it is pharmacomechanical or plain aspiration oblique catheter directed. Above the inguinal ligament, young patients, it is wise to take everything out. If it does not extend above the inguinal ligament, we generally are okay with either catheter directed or simple aspiration and let it be. Below the popliteal, we would not intervene most of the time. So we follow our Society for Vascular Surgery reporting standards, our diagnosis, your classification, and your classification like acute, subacute, provoked, unprovoked. And we try for a class 3 clearance of the thrombus before we come out of the cath lab. As we go, our volumes are increasing slowly and steadily. We do see a significant, to nahi bolenge, but yes, about 1 or 2 per month, we are getting those in all the 3 hospitals that I've worked. And results are getting more predictable now. And long-term follow-ups will start coming up because I've been only 5 years in India till now. Thank you.
Thank you very much. I think Dr. Digvijay, wonderful cases. And certainly, we need these kind of interventions in, acute cases like, you showed in this patient with Takayasus with acute thrombus, and also in patients with DVT, as it is very important sometimes. So tell me one thing, what is the incidence of embolic episodes in while you are doing the intervention in these patients? Have you?
I have not yet encountered in pulmonary embolism because we intervened. If it was a pulmonary embolism, it was already there. Generally, my department will not put in a filter. Rarely, it is a free floating, very labile kind of a thrombus. We would put in a filter from the neck, but not deploy it completely. We would just half deploy it right at the sheath, and once the thing is over, I take it out immediately, sir. I don't even let it be there. A filter, if not available, I would keep a balloon standby again from the neck, just to inflate it if I'm worried. But usually they don't embolize during the procedure. No.
Because, let me tell you, angiojet, the history of angiojet started from coronary interventions. And we were one of the first ones to use angiojet in about 2000. So basically that time in coronaries, we were very, enthusiastic to use it, but actually it led to more embolization in the distal circulation because the arteries are so small. But definitely in, bigger arteries like, or the bigger veins, it is reasonable to use angiojet and give good results.
So actually, as things have developed, when the thromboaspirations and lysis was not there, that were used, suctions, which was more of a mechanical thrombosuction, led to more of embolizations because the cap was disturbed. So gradually they realized that if we keep the cap there and we are just either if you're doing a lysis, keeping macerating the clot, not disturbing the clot too much, the embolizations do happen, because there have been various studies saying that microembolizations do happen, but the treatment itself, I mean the embolism which is life threatening will only be there if there is mechanical disturbance of the clot cap, which can go. So there were some proponents of filter always with thrombosuction or lysis, and now these studies have said that filter retrievable filters, like Professor Digvijay said, that maybe half deployed or retrievable filters for the procedure. It's on a case-to-case basis where the thrombus load is too much reaching up to the renals, not in the iliacs or in the IVC. And free-floating thrombus maybe, if it's recognized before, that may be an indication to put in a retrievable filter. Otherwise, if you're doing pure lysis and maceration, they won't be required. With the other aspect is the hemolysis that happens, that people have had experiences with, that there is hematuria happening with the penumbra, somehow that happens. So that has also been taken into account. So all three have their merits and demerits, but as Professor Digvijay said, that on a case-to-case basis we may decide on a filter.
Yeah, I'll add to what Tapish said. If you're using angiojet for DVT, extensive DVT, you will have hemoglobinuria, period. But usually it is not significant. What I'm more worried about is the bradycardia that comes along with it. So if he has cardiac issues and if he is older than 60, I pace them up before we take up. So the cardiologist will put in a pacing device, and then I'll happily go in and be safe and not worried about the ECG all the time. But yes, if you're using angiojet, you will have hemoglobinuria 100% of the time.
Okay. So I think this was a wonderful discussion on these three very interesting cases. Now we'll move on to Dr. Shastri's. Dr. Vinayak, Vinayak.
Yeah, so I actually, I would like to say two things in this case. One, I would like to know what is the guidelines why standing of these interventions. Because in our day-to-day treatment, when you have NOACs introduced for DVT or VTE, they work reasonably well, except for probably post-DVT syndrome. is there any more benefit of having these interventions in the long run? What is the cost of it? What is the analysis, cost benefit analysis of these interventions in the long run? And I would like to know that those comments as well from both the
This is
intervention.
a very wise question. Let us be very clear about it. So, if where I would push the patient to get intervention would be if it is a relatively young patient, read as less than 40, and it is definitely above the inguinal ligament. Then intervention, I would push them up because, like you said, it's not the pulmonary embolism that I'm more worried about at that area. It is the post-thrombotic syndrome. Now, if you do best medical therapy, you will have post-thrombotic syndrome in more than 70% of the cases. Now, this person is 30 years old, presumably live up to 80. Isko dikkat hogi. But if it is a 65-year-old person, then I will not push for intervention all the time. I'll give them the choices. Yes, cost is very expensive. Let me be very clear about it. By the time the patient will go home, it will be like ICU treatment and then directly home. Ward mein zyada nahi aayega uske baad. Once the thrombolysis is over, we're already onto oral NOACs and through. It will hit about 10 lakhs in those 3 days. Because 3 days ICU stay, 3 days the actualize, one vial will cost you 50,000. वो सब करके 10 lakh तो पकड़ना चाहिए. Then if you have to put in a stent or something, then 1 plus 2 plus minus something. But the point is a single procedure, remove all these, we call it a contemporary deep vein management, DVT management, where we remove the clot and also remove the causes of the clot. And the most important for the left-sided leg is Maytherner's. It is the iliac vein stenosis that we generally do not catch. Now, each time you have a recurrent DVT, it will be worse with more propensity for further complications. So, young person, good healthy lifestyle, above inguinal ligament, I would say better you invest in the intervention part. Otherwise, yes, there are other less ferocious ways of going about it.
Right. Very good. Yeah, Tapesh, what kind of investigations do you do for these DVT patients on a routine basis to, as Professor Digvijay said, to rule it out or to do intervention in these patients? What is your step-by-step approach?
Sir, step-by-step approach, as the literature has suggested with the various trials till date. Actually, the trials were with different kind of interventions. So we need to take it with a pinch of salt, actually, that we have to take in a real world scenario how things are. So as sir said that if it's a left-sided young patient, there is no question that he will need some kind of lysis because it's more or less a May-Turner syndrome when it is unprovoked. When it is unprovoked. So we have to keep into account that lysis has to be offered. When the patient agrees or not, we have to tell them about the PTS because mostly what happens is they come back after say about 1 month, 1.5 months when the period has passed on, and then they say that this is not resolving, now do something. So at least we have this thing that, okay, this was offered at that time. Now regarding on the cost, as Professor Digvijay said, sir, I would like to disagree here. It depends on institution to institution, that it can be 10 lakhs, it can be 5 lakhs, it can be 4 lakhs, it depends on institution. So we have to tell them the costing because some people use ETO catheters, like we have used the Craig McNamara, and we have tried to reduce the cost with. Some people have also tried with UFRAG, some people have tried with other things. So we have to keep the cost low because 10 lakh rupees is not what everybody can afford that way, and it depends on a case-to-case basis. But we have to keep the cost low because these are young patients, and in older patients, if we talk about left-sided DVT, it has more to do with the reducing the tightness and the symptoms. Like if the patient is like last patient was having blue this thing, and she was having some kind of compartment happening. So we don't have a choice there to keep them on conservative management because they are asking for it. I mean, the patient's leg is asking for it. They have a lot of pain. The superficial and deep system both are gone. It's like a phlegmasia picture which will turn into venous gangrene. So you have to select your cases, And mostly, if both the systems are involved, or if it's going beyond the inguinal ligament, if it's involving the iliacs, there are more chances of post-thrombotic syndrome later on. So they should be offered, keep the cost less as possible, be prepared for a stent in young patients, and use IVUS wherever you have the facility to do so.
Yeah,
Right. Very fantastic comments, Tapish. And I think, we are really, we have gained a lot from this discussion. And certainly we'll use all this information, and all those who are hearing will use this information. And now we'll have to move on to the next case. And Dr. Rajnikant Shastri is here. He is with Medanta at Murchand and has been there with us for a little while now. So, Shastri.
Good evening, sirs. This is just a very short case presentation about deep venous thrombosis. So we had a 33-year-old male who presented in the emergency department in the evening, complaining of swelling and pain in the left lower limb, below the knee. So he also had mild dyspnea and a bit of chest discomfort, which had occurred around since past 5 days. His history of presenting illness is that he was a commercial taxi driver who was basically driving from Haridwar to Delhi in a car with 2 passengers. Due to bad weather, he was stuck in an 8-hour-long jam where he was continuously using his left foot for clutch driving, as his words are. So on reaching home, the patient went to a local practitioner who just gave him a few painkillers and told him to rest the lower limb and avoid moving it, and it shall get better on its own. The patient then noticed that the pain was getting worse the next day, and he was now also having a low-grade fever, and the pain and the swelling in the limb were increasing. So then he went back to the same practitioner who said that possibly there is some kind of bony injury, asked him to get an X-ray lower limb, and then said, you please go to a higher center for further management. So the personal history is he's a non-diabetic, a non-hypertensive, and surprisingly, despite being a driver, a non-smoker and a non-tobacco chewer, he gives history of occasional social drinking. He's married with 2 children, and he's also an amateur bodybuilder who basically sometimes take place in the local competitions. And he gave no significant history in any of his family. So on examination, BP was 150/90. His temperature was 99.3. Respiratory rate was 17. And his height was 190 centimeters and weight 106 kgs. He's a tall person. So on examination, on local examination, the left lower limb was very tender and swollen around the knee and below. But I could get peripheral pulses. And the right side was normal. There was no findings in the chest or the CVS. On doing a bedside, what you call a Doppler, there was an intraluminal filling defect seen in the anterior and posterior tibial vein and extending into the popliteal vein. No compression or augmentation there. The deep femoral vein and common femoral vein were normal with good compression but no augmentation. So these were suggestive that there was deep venous thrombosis in the popliteal vein. The right lower limb vein was normal. A bedside echo was immediately done with the same machine. And there was no signs of any kind of pulmonary embolism, and there was mild TR with a PA pressure of 38 millimeter mercury. The RARV sizes were normal, and the TAPC was around 2. ECG showing normal rhythm. At that time, immediately he was sent from the emergency into the CT for a CTPA, which revealed that there was no sign of pulmonary thromboembolism and no sign of RV strain. So the lab investigations were sent, which were relatively normal. All the proteins CS and other coagulation parameters were normal. So patient was then advised admission, and he was put on strict bed rest and started on Clexane, an antibiotic, and paracetamol was given for fever and for pain. So patient was responded to treatment, and next day he felt much better and he was not having that many complaints. The third day when we came back to see him, he then started complaining that the pain was getting worse, has now increased and has got worse in the left lower limb, and now again he's starting to have fever. He was also complaining of mild cough. So on examination, vitals were relatively okay. He was febrile. Now the swelling on local examination, it was now noticed that apart from the knee, even the mid-thigh tuck, we had found there was swelling and there was tenderness. So the systemic examination was normal. We couldn't, there was nothing abnormal there. A repeat immediate bedside ultrasound was done, and this time we found the thrombus had now migrated into the deep femoral vein and almost entering into the common femoral vein. The bedside echo also was done. There was no change from the previous echo, except that now the PA pressures had gone up to 48, and still TAPC was around 1.8, 1.9. So then immediately patient was sent for a CTPA, which this was the venous the Doppler image, the video which managed to get. So in the CT pulmonary angio, the basic report was that there is a non-enhancing focal soft tissue thickening in the segmental and subsegmental branches of the bilateral pulmonary arteries, but there was no main filling defect seen in the main pulmonary arteries, and also there was no evidence of right heart strain. So this was suggestive of pulmonary thromboembolism. So as the patient was maintaining vitals, we decided not to thrombolize him, and we talked with our interventionist. The interventionist suggested, since the thrombus had already migrated to deep femoral vein and there is a CT finding of mild pulmonary thromboembolism, an IVC filter was advised and the same was placed on the same day. And then patient was continued on injection Clexane, 1 milligram per gram twice daily, along with the antibiotic was upgraded to Tazac, and rest supportive management was given. On the 5th post-operative day after the IVC filter, patient started improving. He became afebrile, pain had reduced, and now he was feeling better. He was still not allowed to mobilize. Financial constraints, the patient was discharged on the 7th day on tablet rivaroxaban 15 milligram twice daily, an antibiotic, and other supportive management, with advice to review with a higher center for with an interventionist to find out whether he can get something done there for the. So he's supposed to come back in 3 weeks. That was the discharge. Discharge was done around 3 days ago, 5 days ago. That's the case, sir.
Very good. So I think, Shastri, this is again a very interesting case, or a very daily routine case which we see. And the man, and as we can see here, this patient had pulmonary embolism, although it was neither a massive or a submassive pulmonary embolism. So definitely, if the embolism is not massive, then it might not be necessary to put them on thrombolytic therapy. And only when they have massive, as far as we are concerned, we thrombolize these patients when they have massive or submassive pulmonary embolism. And typically, in this kind of situation, long-term anticoagulation and acute, low molecular weight heparin generally will be able to manage the situation, and which you did. And typically, this patient will be on a long-term. So how long do you want to give rivaroxaban to this patient?
At least for 6 months, sir. And then we'll repeat again, because we've not found any primary cause for his thromboembolism, apart from the fact that he was in an immobile state for 8 hours. The other coagulation parameters, all protein CS, everything came negative.
Mm-hmm. And when do you want to take this filter out, in another few weeks, 3 months?
So we asked him to review in 3 months so that we can reassess again to find out if we can take the the IVC filter out, sir.
Yeah, Vinayak, your thoughts on this case? Anything differently you would do or advise?
So I'm not sure if I would have gone in for an IVC filter straight away. I'm not sure. I mean, I think it's a clinical judgment call, of course, in good faith. The only thing is that one thing which I want to know, Dr. Shastri, is that when he had popliteal vein thrombosis, which anticoagulant had we given him at that moment?
He was actually put on Clexane. He was admitted under the respiratory person before the cardiologist was given the.
What was his weight and how much dose did we give?
He was 106 kg, sir, and they had given only 40 milligrams subcutaneous twice daily was given, sir. He was being underdosed.
Yeah.
They did not account for his body surface area.
Yeah. The other thing which I want to say in these cases is that I doubt that it was that 8-hour journey which caused the DVT. We know that obesity, especially super obese people, grade 5 obesity, these people are prone to develop DVT more commonly than the others. And we should definitely work them up for thrombophilia profile to look for any other causes in these cases. Having said that, I think we should, I completely agree that we probably should have been given 80 milligram subcutaneous BD at least to begin with. The other is when we look at the data, the DVT, which is small, which is not submassive or massive, and patient presents to us with where we're not given a proper trial of anticoagulation yet, and patient is reasonably stable, not so in a way high risk. I think I would have just given him an anticoagulation weighted, because IVC filters haven't shown to decrease mortality in any of the trials. The only reasons we can, which are recommended is when you give IBC filter is when you are unable to give them proper anticoagulation dose is what is recommended. I mean, this is what traditionally we say. Sometimes if they bleed, if they are pregnant, if there is a reason for which you cannot give anticoagulation, that's when IBC filters come in handy. So that's my take on it. Yeah.
Yeah, absolutely. These are very valid comments. And doing a hemophilia, I mean, this profile for these patients is, I think, a good idea, especially even if it was appearing that it is a provoked DVT. But still, since he's a young patient, and as you were saying, 8 hours he was, but I mean, it's borderline. So maybe doing a profile is not a bad idea at all in this case. And certainly doing this filter, I think they actually responded because suddenly the patient became breathless and thrombus is moving up, etc. So probably they just reacted to that. So this is fine. If it is a removable filter, it is okay.
Removable filters.
Yeah. Any
One
comments?
question I just had just to ask: should I advise him to take a few more days of Clexane, or was it okay that I just discharge him on rivaroxaban? It would have been a better idea to let him continue a few more days of Clexane.
I think we can take the comments from Dr. Tapish also, but according to me, I will give this patient at least, maybe if possible, 2 weeks of, low molecular weight heparin, because the effect of low molecular weight heparin is quite, aggressive and nice compared to NOACs. So this is my take on this, and I will continue NOACs as a maintenance therapy rather than the initial. Continuation up to 10 days, definitely, maybe 2 weeks. Tapesh?
Sir, 2-3 things here, sir. One is that placing a filter. Well, yes, I think that it was more of a clinical decision because it was seen that patient is maybe deteriorating. So holding horses, well, it depends on the nerves and the individual cases, how you have talked to the patient, because as Dr. Vinayak said, that we could have given proper anticoagulation and seen before, because there was no cardiopulmonary reserve issues and it was a subsegmental, not a main pulmonary PE that time. Other thing here is regarding the rivaroxaban and Clexane, sir. Actually, we as clinicians tend to depend more on things which we have already seen rather than changing over to this thing. And LMWs have traditionally proved more dependable in such cases. If it goes wrong, if it has to go wrong, even 10%, and if it goes wrong in this kind of a case, you would prefer more dependable things till the life of the thrombus is exhausted in 2 weeks when it started to burn out. So you would depend more on that, although trials have said that 15 mg BD is as good, but you would not want to burn your hands with that 10%, even if that is the case. The other thing which I wanted to ask is regarding the antibiotics for 5 days, and regarding, as Dr. Shastri sir said, that after 6 months we will see and do certain tests and review. So antibiotics and certain tests that we will review is what I wanted to throw more light on, sir, if that is possible.
Why not? Why not? Yeah. Professor Digvijay, you want to say something?
Just a fact that rivaroxaban and Clexane both are factor 10A inhibitors. They basically have the same T half, the same onset of action. So, like Tapish said, we are more dependent on it because we have seen it work. But I guess coming times it will be as good as Clexane, according to data.
But yeah, for prevention of thrombosis, I have seen NOACs work very well. But Vinayak will agree to me, many patients who come to us, because we use it in cardiac thrombus also, those patients who come to us with the LA thrombus or a LA appendage thrombus, when we put them on rivaroxaban, or generally the response is either very slow or it takes months together for that to kind of vanish, compared to either putting them on low molecular weight heparin or giving them VKs. So I think we still see that difference. I don't know. I mean, the data is not definitely supporting all that. But
no,
definitely,
the issues with your patient population is you are basically dealing with cardiac populations. वो atorvastatin वगैरह खाते हैं. They
No,
have
no,
a
these are patients that are not on atorvastatin. These are
Mhm.
basically valvular heart disease patients. And
Mhm.
typically, I'm talking of these mitral stenosis. And many times,
Mhm.
because why I'm saying this, because many times we have to do a balloon valvuloplasty. And then
Okay.
Dr. Vinayak and my friends, when they do a T, they say, oh, no, 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 there is a clot here. Now, if there is a clot, what we do? So then we put them, either we send them for surgery, or we say, okay, you continue anticoagulation for 3 months, come back after 3 months, and then we'll repeat a
Fair
T.
enough. Fair enough.
So that we have seen this kind of, Vinayak, what do you say?
I completely agree, sir. My only 2 cents here is that, as Tapish also said, it's very difficult to break away from your comfort zone or get out of your comfort zone. And traditionally, we've been more comfortable with injectables. Now, if you look at the literature, you can very easily in a patient, especially in a small pulmonary embolism subsets, start, or in any subset actually, which is not submassive or massive or high risk category, you can start with the rivaroxaban 15 mg BD right from day one. In fact, in the trial with rivaroxaban, there was no overlap with the low molecular weight heparins at all. In fact, it is with dabigatran and also with apixaban that you have an overlap that you can do. The other issue is that this patient was 108 kgs. Now, if you look at the literature, most of the literature with NOACs is between patients who are between 40 to 120 kgs. We don't know how the patients who are more than 120 kgs will behave with NOACs. There is limited data in the super obese kind of patients. This guy was still less than 120 kgs, so I guess we can follow the recommended dosages of 15 mg BD for 21 days and then 20 mg OD for whatever duration we decide. And in fact, I have often faced a dilemma where the patient is sent to us with 1 week of low molecular weight heparin, and then you have to decide whether to give them dabigatran, apixaban, or rivaroxaban. Now, I don't have data where I start. Should I start with rivaroxaban, then continue for 21 days after a week of low molecular weight heparin, or should I curtail that and then maybe give it for less duration? So I don't have the data with that, and I guess I prefer to continue with 21 days additional. So these are my comments on these cases.
Okay. Excellent. I think, we had an excellent discussion today. And if there are any other comments, otherwise, I think we are done with the cases. Are we?
Yes, sir. Yes, sir. Yes, sir.
Okay. Okay. Okay.
Yeah. So
So
1 second, sir. Yeah. Yes, sir. Any closing remark from your side?
I think, I think we had a good discussion on these two aspects of, arterial thrombosis as well as venous thrombosis. And I think, quite educational today from all the cases presented.
Thank you, sir. Next, sir, from your end, anything?
Thank you.
Yeah. So once
Bye.
again, sir, from behalf of Emcure, I would look to say thank you so much to Dr. Professor Digvijay sir, and Shastri sir, as well as our Vinayak Agarwal sir, and as well as the Tapish Rao sir for moderating the session, and also from thank you so much, sir, Praveen sir, for hosting this session, sir. Thank you so much, sir, and good night.
Bye bye. Good
Thank you.
night.
Good night. Thank you.